afternoon and welcome to PBA at Noon. I'm Paul Benwell and I'm joined by my colleague Sophie Caesar. Today we have with us Skylight Health Group, which trades on the TSX Venture under the symbol SHG. Skylight is a healthcare services and technology company working to impact patient health outcomes positively. They operate a U.S. multi-state health network that includes physical, multidisciplinary medical clinics, providing a range of services from primary care to laboratory diagnostic testing. They also own and operate a proprietary electronic health record system that supports care delivery to patients via telemedicine and other remote monitoring system integrations. With a patient roster of over 155,000, operations servicing 16 states, and continuing to expand in services and locations both organically and by way of strategic acquisitions, this is definitely a company to keep on your radar. Here to help us tell us more about the company is the CEO, Brad Sikar. Hi, Brad. Welcome to PBA, and start anytime you wish.
Hey,
anybody having questions, just put them in the Q&A and we'll ask them at the end. Thanks so much.
All right, thanks, Paul, for the intro. Appreciate it, and good afternoon to everyone, or good morning, depending on time zone. Appreciate you making the time for the presentation. My name is Brad Shaker. I'm the CEO and co-founder of Skylight Health. Let me kick it off here, and happy to take some questions at the end of the presentation. So just by way of introduction, Skylight Health, as Paul mentioned, we are a US-focused healthcare services and technology company. The company today is traded on the TSXV in Canada and on the OTCQX in the US, with the planned uplist in Q2 of this year, expecting to be in May of this year onto the NASDAQ. Currently, the company generates approximately $56 million in annualized revenue run rates. That's pending the closing of all announced acquisitions. We have a buy and build model with a very strong pipeline at very favorable and attractive multiples. On the revenue, the company generates positive EBITDA and cash flow from operations, no long-term debt, and a strong cash balance of over $7 million to effect against the acquisitions. Just by way of quick background, prior to Skylight Health, I've spent over 15 years in the field of clinical practice management, working mainly with outpatient physician practices, both in the Canadian and US side. Skylight Health is really focused on the US market because, unlike the Canadian market, the US market is a far higher reimbursable market where you generate far more revenue from insurance companies. And of course, with the way physicians are remunerated by salary or fixed fee, generates stronger gross profit margins and much stronger net margins as well. Unit contribution for medical practices in the US are expected to be between 20 to 30%, and that continues to grow with more involvement of technology as well. So just to cover where we play, what we do in the US. So as I mentioned, Skylight Health, we focus on the primary care market in the US. So primary care, or family physicians, as you call it, for a long time has reflected a much smaller piece of the total US market. It's about a $3 trillion US healthcare industry, of which primary care is reflected less than 10%. However, primary care is responsible for more than 60% of the healthcare costs. And so what we're starting to see now in the US is a major shift in how insurance providers are reimbursing doctors for services. So unlike the Canadian model, in the US, we deal with a number of different insurance companies. We don't deal with a single payer system. So we have government payers like Medicare and Medicaid, and we have commercial insurers like United Health Group and Humana. And what happens is when a patient goes into a doctor, similar to Canada, the patient, based on their health plan, sees the doctor, and the doctor bills the insurance company for that visit, and they get paid from the insurance company for that visit. Traditionally speaking, how it used to work is every time a patient goes, the physician gets paid. So it's an encounter-based model, or otherwise what we call as fee-for-service model. Now, in a fee-for-service model, in order to make more revenue, you have to see more patients. And so volume really is of the utmost importance for family doctors. What this has done is basically gotten the insurance companies to kind of wake up and say, look, with physicians focusing on volume, they're not focusing on actual quality of care. What this is leading to now is basically a rising cost in healthcare, where hospitals and hospital-based services are really accelerating their cost of service because patients are likely avoiding or sort of going to the hospitals based on issues that could be avoided if family physicians were spending more time and focusing on quality over volume. And so basically what this has led to now is insurance companies are going to be changing their reimbursement strategies to doctors from traditional fee-for-service to what we call as a capitation model, the future model of healthcare, which is a per member per month. So it's a fixed cost per member per month. Now, this leads to, first of all, a dramatic increase in how much a family physician can make. But more importantly, this shift is going to require a significant amount of infrastructure and investment from a clinic to be able to deliver services under this new model. What the opportunity is for Skylight Health today is that the majority of family physicians in the US today, nearly 56% or more, operate under an independent model, which means they work by themselves or in small group practices. They also operate under fee-for-service. Fee-for-service is still the dominant form of model in the US. And so while the insurance companies are really focused on driving this change, they face a dilemma. How do we help these small practices make the right investment in time and cost to effectively deliver care under a capitation model? And this is where Skylight Health sees its biggest opportunity. So we are in the near term a fast growth company highly driven by acquisition. Why? Because we're focused on these small to mid-sized physician practices that need the most help in moving over. Because we're focused in a market today that's relatively early, we get the benefit of acquisition. Sorry, I should have moved to this slide before. We get the benefit in acquiring these practices at a steep discount to where these practices are after they've made the conversion. So we favorably acquire these practices. We then bring them onto the Skylight Health platform. And under the Skylight Health platform, we're investing in the technology, in the infrastructure, in the people, and in improved contract negotiations with payers. Under the Skylight Health platform, these practices are now able to see a pathway to transition to a capitation model, which can result in over 500% improvement in the existing book of business. And so there is tremendous organic potential in being able to help these practices make their way into the new model. So just to validate what some of those numbers look like, here's an example of two capitation models for Medicare, which is for anyone who's 65 and older in the US, you go under a Medicare plan, which is a federal program. Or if you make under a certain poverty line, you go into a Medicaid program. So these are both government payers. Commercials are typically higher. But in a Medicare program, so Medicare Advantage is probably the fastest growing segment today in capitation models in the US because we're dealing with a much more aggressively accelerating senior care population. So the number of seniors today in a Medicare Advantage product are about 20 million out of the 60. And this is going to accelerate significantly. As you can see here on the right, Aetna, which is one of the largest US insurance payers, is committing themselves to 75% of all claims being value-based or capitation-based by 2020. Now, we're clearly past 2020 and they're not at 75%. And the reason is because so many of these practices are struggling to make their way there. And so again, it validates Skylight Health's approach to the market. Now, under a Medicare Advantage plan, the per member reimbursement, meaning as a physician, I would earn approximately $1,000 per patient per month or per member per month. So that equates to about $12,000 a year. A patient that's on traditional fee-for-service, the old model, Medicare, is probably generating only about $125 to $300 a year. And so you're talking about a value of $300 a year to $12,000 a year. And this is really what that 500+% growth comes from. You're really doing nothing more than just building the infrastructure to what the insurance companies want and then benefiting from the contracts that they are looking to award. And so this is really the upside opportunity here. Now, as you can guess, with this much sort of growth in patient value, this must be a busy market. And the answer to that is yes. But here's how Skylight Health is different. So I'm going to use two comparables here as companies to sort of highlight why Skylight Health is different in the market. So both these companies are, first of all, US companies. One of them is public today, Oak Street Health, and they trade under ticker OSH. The second one, Kano Health, will be coming public this year. Oak Street Health took an organic route to the market. So they decided to open up offices and organically recruit patients. Now, when you open up an office from scratch, as we've done many years, you will take about 18 months to 2 years to get a full patient capacity. And that's because you're recruiting patients month on month and growing your patient count. So until that time, you're investing a significant amount of capital and infrastructure and people. And so there's a higher upfront expense. And so Oak Street Health's margins are typically lower than what we'll see in most clinics. Their gross margins are usually around 30 to 40% today, versus Skylight's gross margins are about 65 to 75%. Now, what Oak Street Health did is they focused only on the Medicare Advantage plans. And so they have about 80,000 patients today. Now, remember, we talked about 12,000 per year. On those patients, they're generating approximately 1.3 billion in revenue. And so that allows them to obviously, number one, receive from an organic perspective, a 13 to 15 times multiple on revenue from analysts. And you can see that based on that patient count, that's a substantial return. Skylight Health has nearly doubled that patient count, but is only doing about 56 million in revenue. And that's the value arbitrage we will close organically for shareholders by leveraging our infrastructure and platform to move them into the same capitation model that the insurance companies are paying for today. Kano Health is another example of a company that's doing something similar to Oak Street Health, but they're doing it by acquisition. So they said, look, we don't want to take 2 years. We're going to acquire practices and we're going to quickly grow our patient base. But we're not going to buy practices today that are fee for service. We want to buy practices that are already doing capitation. So remember what I said earlier, over 56% of clinics are fee for service. So you're dealing now with a smaller subset of physician groups. It's also a very highly competitive market. And so you can see the price that Kano Health pays is nearly double what we pay for acquisition groups. And the organic growth beyond that is substantially less, because once you've already converted, how much more can you really organically grow? So where Skylight Health is really creating a unique footprint of growth in the US is similar to the other companies, we are driving the company towards capitation, the new model from insurance companies. But we are doing it by way of acquisition, similar to Kano, meaning that we will aggressively grow in total patients under roster. In the last 5 months, we've acquired over 50,000 patient lives. And so our rate of growth is significantly faster than anyone doing it organically. But unlike Kano Health, we are buying the fee-for-service practices, the larger greenfield, mind you, that nobody really is focused on. And by doing that, we get a significant discount to the market. Now, if anyone says, how sustainable is that? Well, we're talking about hundreds of thousands of practices. This is a much larger market in the US. And so supply is never going to be an issue in the near term. This is going to continue to become a very accretive form of growth for Skylight. Now, the organic growth we leverage beyond this, that is recognized 100% by shareholders, which is why the feedback we continually receive is Skylight is in a perfect position, like Oak Street, to receive a multiple on revenue based on that organic delivery back to our shareholders. So how have we done this and what have we done? So in the past several months, we've made a number of different acquisition announcements, most recently last week when we announced, I'm sorry, it might have actually been, it was last week, this week, we announced the closing of our latest acquisition, Rocky Mountain Group in Colorado. So over the last few months, we've made 7 announced acquisitions. These acquisitions have led to immediate revenue growth on the company, allowing us today to see an annualized revenue run rate of 56 million. Then another thing to mention is, as I talked about earlier, the US market's profitability margins are higher. Each of these practices on acquisition are cash flow positive and profitable. And so it continues to strengthen our own position of cash flow positivity. As we acquire these practices, we're staying disciplined in our purchase price between 4 to 7 times EBITDA. And more importantly, the revenue that we are acquiring are fee-for-service revenues, which means that conversion to capitation will lend to that 500% growth. Once we acquire these practices, what we're in the focus on today is really integrating and creating a single system of management. And so in order to allow us a model that can deliver capitation, and the reason why so many of these clinics struggle is that they don't have the ability to actually aggregate the information they need in order to understand how they're delivering care under a capitation model. If you don't do it successfully, you will lose money and patients. And so what do? We have a technology at a core that allows us, from a data analytics perspective and from a data integration perspective, to be able to capture data from a variety of different important sources. billing data, patient healthcare data. And this allows us to really do some important things that are important for the insurance companies, which is how many patients are meeting various quality metrics by way that they then determine how much do we get paid as an organization in that per member per month rate. And so installing this infrastructure is critical. And this is part of what we have internally as a proprietary technology platform, allowing us to be able to go into these practices and bring this to them. Apart from this, we're also strengthening their operations, we're improving on their existing workflows, and naturally seeing some cost efficiencies and overall revenue enhancement within these practices. Once we're able to establish this, we can now start to approach the payers and really the insurance companies and really start to now go after improved contracts with the insurance companies that allow us to benefit from capitation. Now, again, these contracts aren't something that we have to sell. These are contracts we just have to meet. And so these parameters of these contracts are already defined. As long as we're able to check the boxes, we get a chance to participate in those higher value contracts. And that allows both the practice to get a better financial performance, but also the patients to receive a better quality of care. So where the company is today, as I mentioned, on the TSXV, we're traded on the OTCQX with a planned uplist in May this year. We are covered by 4 research analysts in Canada, most recently through Raymond James. The company has seen exceptional growth in the last 6 months, again, reflecting against our buy and build strategy. And as we continue to look towards expansion in the US markets from both an institutional capital markets perspective, we are looking forward to research initiation in the US markets as well. But also as we continue to execute against our buy and organic conversion story, the company, we believe, is just in its early innings today. We have strong insider ownership. Management, including founders, still hold all shares from day one, and we continue to accumulate where possible. And from a perspective of growth, we certainly see a lot more runway as we look to execute here. Just based on numbers alone, just to give you an idea of what we're sitting on, based on our current revenue book of business, we easily believe that in the next few years, this revenue can translate to well over $1 billion if we did nothing else. No more acquisitions, but just focused on organic growth of the existing book of business we have today. And so certainly I think US investors are recognizing that, especially those that invest in the value and capitation-based space, understand the revenue growth you can have under the new insurance model. And what Skylight Health today is doing in accumulating a large number of early stage companies in the old model and bringing that growth in a post-acquisition mindset is certainly where we believe we will continue to see rapid growth, especially after we make a big catalyst move onto the NASDAQ. So just highlighting sort of how it gets there as well is our operations and leadership team. I mean, apart from both Cash and myself, who are co-founders who have had most of our professional experience working in the clinical practice management industry, behind us also stands executives from multi-billion-dollar healthcare systems in the US, including Paul Koulis, that just joined us from Providence, one of the 4th largest health system in the US, Dr. Fagali, similar with our payer and contracting, our clinical leadership, compliance, and financial teams. We are really geared towards a US-focused organization with an infrastructure that is largely US-based today. And so as we execute against our plan, we are not only doing it from a founder perspective, but more so from an executive experience and bench strength. We are bringing a lot of experience to the table, and that is how we're seeing this organic growth convert as we continue to acquire new practices. The same goes for our board of directors. And so the most recent addition to our board was Patrick McNamee. Patrick, who brings experience building multi-billion-dollar healthcare companies in the US. For those of you who may know the name, he was the EVP and COO of Express Scripts. Express Scripts that just recently got sold to Cigna, but he took them to over 120 billion in revenues. He also turned around HIIQ into a multi-billion-dollar US publicly traded company after a failed IPO. And he also ran GE's healthcare division. And so having Patrick on the board has certainly attracted a lot of attention from bankers and analysts, but also from an operational capacity will really bring the leadership to help management in executing a multi-billion-dollar revenue strategy. So Paul, maybe with that, I'll pause and turn it back to you for any questions. Or Sophie, I'm sorry.
No worries. Thank you so much, Prad. We do have quite a few questions, so we'll get right into them. What is the barrier for the clinic to change to the capitation model, if there is one?
Of course. So essentially, the way we can think about this is from a numerical standpoint. For an independent physician to invest in the infrastructure you need to deliver proper capitation-based care, it's roughly about $20 to $25 per member per month. Okay, now if I think about an average practice of 2,000 to 3,000 patients, that's a substantial investment for an independent physician to do. Now, mind you, most capital is not available to independent doctors. It's not like they can go raise money from the private markets or leverage bank debt to make this investment. Because the bigger fear is, as an independent doctor, the way capitation works, just to give you an idea, is, let's say I get paid $100 per member per month from the insurance company. Now, I'm supposed to deliver a certain amount of care to that patient, which means I'm supposed to minimize the need for them to go to an emergency room or an urgent care. So I have to have potentially after hours care for my patients. If my patient goes to an urgent care, then I potentially have to pay in regards to a penalty for not meeting certain minimum thresholds. So a lot of physicians who have to invest personal dollars with a fear of not knowing how to do it properly could stand to lose money. And that has really acted as a major barrier for independent physicians. Now, having worked in clinical practice management for so many years, even in a fee-for-service model, there are areas where we can see a 10 to 15% improvement in cost and almost a 50% improvement in revenue just by enhancing their operation. These are traditional business strategies you can deploy. So you've got physicians that are great at dealing with patients, but have not necessarily had the capacity to run an efficient practice. Now you're asking them to invest more money and go into a new area of delivery. This is really a capacity, knowledge, and capital issue. And so this is why this road to capitation has been going on for 10 years, but the adoption and conversion has been slower than expected. And I really believe that the focus has to be on these small physicians, because if you think about it, 56% of them, they hold the majority of patient population in the US today. So this is why it's such an important time. And it's so opportunistic for Skylight to be focused on this market while everyone else is focused on the destination. You know, we're really focused on bringing this market to that destination.
So here's a tough one from the patient's perspective. We have a question here from John. Explain getting a better quality of care. So he's sitting at home, healthy or not, he's paying for nothing. So how do you know he's not deteriorating?
Okay, so I guess from a perspective of payment in the US, regardless if you're on fee-for-service or capitation, you're paying a healthcare premium, right? Because we don't, in the US, they don't just get it for free unless you're Medicaid and you're low income. Now, from a patient's perspective, you don't actually notice a change. You will pay the same premium. It's how the doctor gets reimbursed from the insurance company. And so it's not like you're recruiting patients into a capitation model, you're recruiting the contracts into the capitation. So let's say I'm a doctor today with United Health, and I have a contract with United Health Group for 500 patients. Those 500 patients, if I go to United and say, I want to move to a capitation model, well, United's going to start paying me a per member per month. But it doesn't change anything on the patient side. The patient still pays the same premium. So there's no change to the patient's life. But from a quality of life perspective, it dramatically improves their life. And so if you think about it today, the average patient, I fall sick, I call my doctor's office, maybe I get through on the 4th ring, I book an appointment, hopefully I get it this week. Then I have to go in, I have to sit in a waiting room for 2 hours. I go in, my doctor rushes through an appointment with me. I'm not allowed to talk about 3 other things that are important. I got to go back and make another appointment. Right? So this is a very inefficient system. In a capitation model, the doctor makes the same money whether he sees the patient or not. And so he's not incentivized to be a mill and just pump patients through. And so from a physician standpoint, I can offer things to my patient now because I'm earning more from the insurance company. I can have a nurse hotline. So, hey, patient, if you can't reach me, you can speak to somebody in my practice who has access to your records. If they need to intervene, they can. If they really need me to see you, they can contact me and I can book you in. And when you come in, take half an hour. That's okay. I'm here to be there for you regardless. And so from a patient's perspective, there are so many ways that capitation improves the quality of life that realistically speaking, it should have been the way it was from the beginning. But the payment models didn't support quality. They always supported volume. And now the insurance companies are aligning with what physicians should have been doing, because they're realizing that they're spending millions and millions and millions to hospitals because these patients are coming to them if they could have been avoided from the beginning.
That's an excellent point. So now what happens if President Biden puts a medical plan in place somewhat to what we have here, Medicare in Canada?
So that's actually the best thing that could happen. So a Medicare for all, actually, let's put it as Sanders actually said it, right? So Medicare for all. Why Medicare for all? Because Medicare on its own is a government-based program. Now, you're not going to, you know, my personal opinion, you're not going to move to a single payer system in the US because you have far too many roadblocks there. You've got multiple insurance companies, but what you can do is you can sort of negotiate and fix prices on Medicare. Now, that's not going to affect primary care. That's more to affect hospitals, because the reality is I could go and get an MRI at one hospital and it's $6,000. Then I can go to another hospital and it's going to cost me $18,000. And why? That's just the way the system works. And so really the reason for a Medicare for all plan would be to structure and standardize some of these payments. So not primary care doctors, but call it downstream providers should operate with more consistency in pricing. Now, a Medicare for all is the same thing that they're driving towards now with capitation. It will still go towards quality over volume. And so in a Medicare program, being able to contract under capitation, as you can see, Medicare Advantage is $12,000 per member per year. So it's not like it's cutting back. This is actually going to further enhance. What I think we have to keep an eye on is primary care doctors are the gatekeepers for these healthcare costs. The way the insurance companies look at primary care doctors is, I would rather incentivize you up front and therefore save my downstream cost. And so the benefactors of any of these healthcare transitions is going to be the family physician. This is the decade of family physicians. It's the best time to be a family physician. So, you know, to us, this is opportunistic, it's necessary, and it's great that the markets are kind of stars are all aligning towards this.
So how does that family physician, that doctor, approach his clients and go from a pay per visit to a member plan?
So it has to do with the insurance company. And so, you know, one of the things that Skylight Health has on its platform is we have basically a centralized, what we call is revenue cycle management, but that's the process in the US of, you know, billing an insurance company, fighting against any claims they have and collecting the money on the back end. And so part of that is contracting. So in the US, you have to contract with every insurance company. So let's say there's 10 insurance companies in my area. I, as a physician, need to go to them and sign a contract under which there'll be specified fees that can be paid to me as a physician for what I do, right? There's no barrier to contracting, you just have to contract. So what happens is, as a physician, if I decide I'm now ready to take on capitation, I go back to my insurance company I'm contracted with and I say, listen, I'm now ready to take on capitation. Let's change my contract from $150 per visit to now $100 per patient per month, right? And the insurance company is going to say, sure, I want to do that, but now I need you to show me every month how your statistics are going to help me manage my costs. And if my costs are going down, then I'm going to keep giving you more. If my costs go up, then we're going to keep penalizing you. And so that's how the system works.
So then how long does it take to onboard a small clinic, and when do you start seeing revenue increases?
So roughly the time of a practice from sort of LOI to closing, 60 to 90 days. Sometimes it can be accelerated, sometimes it takes the 90 days, depending on who the seller is. Usually within the first 12 months, we're already seeing improvements in that practice, even within the old fee-for-service model, because again, we're bringing a number of centralized management platforms. We're also bringing efficiencies to the practice that are management focused. And so our practice management skill sets allow us to see enhancements in that business even before we think about changing them to a capitation model. Usually within 12 months to the next sort of 12 to 18 to 24 months, you can start to see that shift in, once you can put the infrastructure in place, you train the providers, the staff, you can now start to move them into the capitation model. And that really starts to grow on, you know, transformatively on that revenue per patient per year basis. So there's immediate, call it immediate growth through acquisition. There's short-term growth from efficiencies. and then there's sort of medium to long-term transformational growth through conversion into a capitation model.
Okay, thank you. I see that Paul's joined us. I'm sure he has a question or two for you. Paul, do you want to ask?
Yeah, just a couple. Do you own or lease most of your properties, like where your clinics are?
We lease them. We're not in the real estate side.
All right, so that was my point. So you're not going to have any future revenue from owning a building or something like that?
No, we prefer at this point in time the flexibility, especially as we scale and grow, to have the opportunity to look at larger practices, but also, it's very important for us to stay hyper-focused and disciplined in what we're doing. I mean, there's a massive opportunity to execute what we're doing successfully. So we have no reason to think about complementary revenue streams that are not directly tied to the core business. We do have complementary revenue streams we're thinking about, like clinical trials, for example, where we've now partnered with a clinical trial provider in the US where, call it hundreds of trials happen annually in the US from traditional biotech and pharma companies and are looking for patients for recruitment into trials. Well, we have physical locations, we have technology to identify them. There's really no cost in it for us, but meaningfully it could be, anywhere from $1,500 to $15,000 per patient per trial. So that's a parallel revenue stream that makes sense. So things like that, thinking about data access, things like that, but not in terms of real estate.
Now, the states that have cannabis and CBD that's legal, do you offer any services for medicinal cannabis or CBD products?
So never products, never in terms of sales. We don't sell pharmaceutical products. We don't sell any kind of allied health products. That's not what we do.
Referrals too?
I'm sorry?
Referrals too? I mean, would you take on a patient that's in pain, for example, and the doctor might say, and he asks about CBD or cannabis, would you have a connection to send them to, or a local, a dispensary or whatever?
Not referrals, no. So, I mean,
okay.
So in terms of for example, one of the things that we're truly proud of ourselves is, number one, we're 100% agnostic. So, Walgreens or CVS, right? There is no referral agreement here. So our patients can truly go wherever they need to go based on price and cost, right? That works the same for any vendor. And I think that's really important for us to maintain a differentiation on. In terms of the question you answered though, but the idea of, call it holistic or alternative medicine, is something that we as an organization are supportive of. So if a patient is treating pain and as part of pain, they're looking at, say, CBD or medical cannabis, well, as a family physician, we're treating, the patient. And so more than likely that physician is maintaining that care of that patient, but it comes down fully to that relationship between that patient and physician.
I got you. Now, you're making a lot of acquisitions. How are you going to finance these? Do you have lines of credit already in place?
Yeah, so far we've been, benefiting from equity capital markets as the cheapest form of currency. Our stock has seen exceptional growth since September, and we've been able to raise a significant amount of capital based on that. Based on our business, we're not burning any capital operationally, and so therefore 100% of our raised capital can actually go to acquisition-based growth, and that's what we've been doing. We still have a fair amount of that capital left in the bank, and so for the time being, that's still our major form of use. We're careful how we use equity. Equity on acquisitions has hurt us in the past, where providing equity to an investor that's not as sophisticated will come back and hit you when it needs to. And so we're mindful of who holds our stock and sort of how we want to use stock as a currency. But that being said, there are opportunities, and we have done that with some acquisitions where we've used some equity as an upside earnout that gets released, well into time, but at a very small amount that doesn't actually impact our daily volume. In terms of debt, we still maintain to be debt-free, although now with being able to be much more positive from a cash flow standpoint, we have started to now have conversations, mainly on the US side with sort of traditional credit lending facilities, where we can look at drawdown line of credit facilities in the opportunity where we see something more attractive. But like I said, for the time being, there's enough cash to move into the pipeline that we have, and certainly moving beyond into Q2 and post the uplist that we have planned here for Q2.
Okay. Sophie, do you have, I think, another one?
I do. I have a couple more questions just came in. When you're talking about the acquisitions, what characteristics other than profit margin do you consider when you contemplate acquiring a practice?
Good question. So there's a number of factors that come into play. Number one, stage of practice. So is this a practice that is still predominantly fee-for-service, or are they taking on capitation today? Because that'll affect the multiple that they think they're going to receive. Number two are contracts. So is the practice currently contracted with any payer groups? Who are they contracted with? Because again, that's important for us as we look to establish sort of national partnerships with various contractors. If they already have a significant, so for example, let's say we're contracted with United, and under United, we already have a per member per month contract. Well, if I'm buying a practice that has 50% United Healthcare patients, I automatically know in the next month, 50% of patients are going to be under my contracts, which are going to be at a much higher reimbursable rate. So payer groups are important for us to measure as well. Patient demographics as well. Sometimes we have a lot of self-pay patients versus insurable patients. As you know, in the US, uninsured patients, represents almost 20 to 30 million people. So there's a big issue with cost of insurance in general. So that tends to play into the decision-making. And then there's the common factors like, the providers, the quality of the providers, the management staff, the existing staff. A lot of the acquisitions we do maintain a lot of their independence. So we keep their staff in place. We keep their office managers. We bring the support. We're more like the firepower, right? But we need them to have a sufficient infrastructure that will be able to continue to maintain the operations.
Okay, I have one last question, and I'm really hesitant to bring it up, but if you want to list on NASDAQ, you have to get your share price up.
Sure.
Does that mean a split's coming in the stock?
Probably. I mean, we've got an approval from shareholders for up to a 5-to-1.
Okay.
Now, what I tell everybody that sort of looks at me and goes, split, I go, listen, there's two ways to look at the split. One is I'm already on the NASDAQ and I need to split to maintain my price. Or two, I'm doing the split in order to move to a larger market where we have substantially more investor demand, especially at an institutional level. And
yes.
So the way we are is the latter. So, we've got great sponsorship in the US, working at banks like Oppenheimer, Stifel, Raymond James, BTIG. And we've been on, I don't know, maybe 40 to 50 meetings so far with US institutional investors. And we're talking about funds that are, no less than 5 to 10 billion asset under management that invest specifically in value-based capitation healthcare companies. And so these are long-only funds that have shown great interest in the Skylight story, cannot participate because they can't buy over-the-counter paper, but are basically now there from a demand perspective. Now, most of these funds will typically look for the right capital structure when it comes to investing in companies, especially as they will invest to support in the aftermarket. And working with our bankers and institutions, it's not about the share price, but rather about the cap table that we will take guidance from some of these funds. Because again, I think it's going to be hugely beneficial for Canadian investors to have these kinds of investors in our cap table, especially from an acquisition strategy, from a capital perspective, but also from a support in the market perspective. These are people that will support you in the aftermarket. And so we've done a lot to lay out our IR strategy, our capital market strategy in the US, including having Patrick McNamee, like I said, coming on the board, who himself comes with a massive fan base behind him. And so the success on how to succeed on a market like the NASDAQ is sort of baked into the existing cap table today. And I think that's going to be hugely beneficial for our shareholders. And I think one of the things to mention, Paul, is that while this is still a US operational story, we're a Canadian listed company.
Yep.
There aren't a lot of opportunities for Canadian investors to participate in this sector in the US healthcare market, which is seeing transformational growth. I mean, you see Oak Street Health today, they're one example. There's another example of 3 companies, Agilon Health, Privia, VillageMD, who've all filed for their IPO this year and will all be north of $10 billion in market cap. And they're all backed by Goldman Sachs, JP Morgan. So there's going to be a lot of investor attention this year in this sector. I think it's a great time to be on the market where the investors can participate.
No, I agree. And I think that's about wraps it up. Sophie, we're good here?
We are.
Fred, thank you so much for your time. Great presentation.
Thank you for the opportunity. I appreciate it.
You got a great story. And I think being in the US, the way things are going down there, you're going to be onboarding a lot more patients, I'm sure. So thanks for your time. Thanks for everyone
Thank you very much.
attending, and take care, everyone. We'll
take
see
care.
you.
Bye-bye.
Bye-bye.
Bye-bye.